Hello, this is Dr. Abbasi from Tricep Brain and Spine Institute, and I'm here with Ali, who's from University of Chicago. We are the authors of the minimal invasive OLIF procedure as well as minimal invasive direct thoracic. Now, this is an educational video about the minimal invasive direct lateral. This is our next paper. To start with, I like to show a little about the history of the spine, and that's the picture that shows that best. Practically, when a disc is worn enough that it's not functional anymore, the standard of care is that we remove it and make the bone above and below to grow back together. This procedure is called fusion. We started this in 1950s with PLIF, posterior lumbar interbody fusion, and this procedure is still being performed in 1980s and until now. The TLIF, transforaminal lumbar interbody fusion, is a standard of care. And to explain that, I'm going to turn back to the a model. In a normal, this is a model of the spine. This is the tailbone, and these are the spine and spinal processes. If we look at that this way, we see that we are dealing with facets, and in a PLIF, we remove the medial part of the facet, and I'm going to take some probe to show it maybe a little better. The medial part of the facet is removed in a PLIF. Spinal cord is practically moved a little to the side, so we get access to the disc base in this direction. Obviously, there is some pressure on the nerves, and in 1980s we noticed that we can safely take entire facet off and go through the foramen itself, and this procedure called transforaminal lumbar interbody fusion. And if you turn back here, this is the procedure. And later on, the other procedures are brought to life, including direct thoracic or XLIF, same procedure, different company, as well as going practically anteriorly, opening up the belly, going to the front of the disc. And if I turn back here, in a ALIF procedure, and this is a true ALIF cage, we open up the belly this way or this way, and push the abdominal organ, including the bowel and retroperitoneal organ, either to up or to the side until we get access to the disc base. If we go back here, going from the front would be the ALIF, anterior lumbar interbody fusion. Going from the side is the OLIF, that's called with one L. It's brought to life by Medtronics, where the retroperitoneal organ or peritoneal organ are pushed to the side rather up. But either way, this is a procedure that we go to the front of the disc and then take the bad disc out, put a spacer in. Patient is in prone position, meaning belly up, and then still the most stable construct is when you then, after you finish that, turn the patient to the back and put pedicle screws. Pedicle screws are screws that going through this structure here, which is called pedicle. So top of the screw is up here, and screw goes all the way inside of the vertebral body, and are connected together with the rod in the back to provide a stable construct. Now, either in the anterior lumbar interbody fusion, OLIF, or direct lateral, or Medtronic OLIF, the patient is positioned either in the what we call supine, meaning belly up, or to the side, lateral decubitus. And I'm going to show you now a picture of what that really looks like in the traditional DLIF, where we go directly lateral, and this is the approach we take. Patient is positioned one side down, and we have to break the bed. It's very awkward positioning and take lots of time because we are trying to create a space between the rib and the iliac crest. And for that reason, actually, direct lateral interbody fusion is made to approach L1, 2, 2, 3, and sometimes as well 3, 4, and 4, 5. The reason is that if again we go to a model here, is if this is a lateral view of the spine, at each level a nerve coming out, and this nerve, I'm going to use just this pipe cleaners, they get together and they come together, create the lumbosacral plexus. And you can imagine now that further down you go, it's getting more crowded, and there are more nerves down here to be damaged. Meaning that it's easier to do 1, 2, 2, 3, 3, 4, but the time you get to the 4, 5, there are too many nerves in your way that can be damaged through the direct lateral lumbar interbody fusion. So the risk of nerve damage is significantly higher in the 4, 5. In the 5S1 down here, because we have the ala of the sacrum as well as the iliac crest is in our way, like my hand would be, exactly like my hand would be, it would be extremely difficult to get to 5S1. As a matter of fact, it is practically in a direct lateral interbody fusion in a traditional way in a L5S1 is practically impossible. 4-5 as well, very difficult, and complication rate is very high. It's technically possible, but literally the direct thoracic interbody fusion, or this approach, is reasonable from L1 to L4. Now, we have published already papers about our OLIF procedure, and here if you see the direct approaches are PLIF going directly down, the TLIF a little to the side. There's a far lateral approach. OLIF is literally goes in a distance that gives you 45-degree approach. In the direct lateral, you go directly on the flank side, and our minimal invasive is somewhere between 15 and 20 centimeters, depending on the patient's anatomy. Obviously, if patient is bigger, has more posterior tissue, we have to go farther down, but we aim in the lateral and AP view for the upper third of the disc, and that's how we determine how we approach the direct lateral. Now, having said that, the question becomes, why not do OLIF all the time? I mean, because in many cases we are successful just to do that. The answer of that is patient's anatomy, and I'm going to turn again to the model here that shows here how the real approach is. If this is, let's say, the nerve root that comes, and the nerve root goes just below the each pedicle here, in a OLIF procedure, we are choosing actually an approach with a probe, and the probe goes in the Cambine triangle. And the Cambine triangle, it's maybe a little harder to see here, but I have to stand up and get it to the camera a little better, is this position right here. In many cases, this is not possible. Now, in those cases, we are actually going not posterior to the nerve root, but actually anterior to the nerve root, and this procedure, and this is a direct lateral. Now, in the traditional direct lateral, its approach is like that. Patient is laying down, and this is the approach. In the OLIF patient, in our minimally invasive DLF, patient is actually prone, and the approach is somewhere between a traditional DLF and OLIF, so somewhere here, but still the entry point is anterior to the nerve root. There are some pictures on my webpage that we are going to go through which demonstrate the difference very clearly and what this advantage brings. Now, let's go back to some of our pictures here. This is a traditional DLIF approach. Now, if we go again, we see the skin markings. And again, skin marking on a real patient, this would be practically the far lateral. That's more like a OLIF, and this is the direct lateral. The MIS DLIF approach would be somewhere here, but in every patient different, but biplanar fluoroscopic imaging clarifies where the approach should be. The positioning of the C-arm is no different than the OLIF, with the difference that we here sometimes we airplane the patient a little more so that our instruments are not exactly in the way of the X-rays. Now, the covering of the patient is no different than the OLIF, and I'm going to just refer to the OLIF paper for the details of that. And here you see the biplanar fluoroscopic imaging. Now, here you see I'm doing the marking on the patient, and what you don't see here, that is probably that the patient is just a touch airplaned to the side. So even though it seems that I'm coming at an angle here, that would be 45 degrees, but because the patient is actually rotated, I'm much more lateral than you would probably notice here. And here's the picture that you see. In this picture, you see that the probe is actually resting on the osteophyte right here, and if we go further, again here you see that we are going to look at more picture here that shows very clearly that this is the entry point, and this entry point is actually anterior to the vertebral body. In other picture I'm going to demonstrate, because that is extremely important understanding of our procedure. Now, after the probe is inserted, the rest of the procedure is no different than the OLIF. We use a tube system. We use the series of intelligent tool to do the discectomy. We place the tricalcium phosphate or biologic. Then we put a cage in. I think it as well is important to know that the cage that we put is the same conical cage that we use in OLIF, has a lower footprint, and lower footprint help us to actually reduce the damage to the surrounding structure. For that reason, we are able to do 4-5 and even 5S1 MIS DLIF, which in traditional way would be practically impossible. Now I'm just going to jump a few steps, and here you see that the K-wire is going completely across, and there are other pictures that shows that even better. And again, here patient is rotated, and this is a direct lateral approach. Now it seems a little crowded, but we have a very special setup in the OR that makes it possible. And here when the tube is in, and here you see this would be a OLIF approach, and he's here. We are in this patient, because tissue is very thick, we are truly have to go completely lateral to the flank to get the right approach. Generally, somewhere half between the traditional OLIF and traditional DLIF, our approach would be possible. This is as well interesting picture that you see here, that you see the cage is placed, and we are going to look at some other picture that exactly makes it very clear. Again, OLIF approach, DLIF approach, you see the different, and for understanding of that as well is important to know which trajectory we are taking and what is the goal. Is the goal cambium triangle, or is the goal lateral vertebral body? Now let's go look at the picture that really matters. Here you see that in the cage, the pins, the cage is like a conical shaped pin, conical shaped device that has two pins, one in the front, one in the back. You see in the lateral view, the cage, the pins are superimposed. That means this cage is practically totally lateral. Here in comparison, you see the pins are not superimposed. I'm going to jump to some other recently pictures that we did, and here that's where you see that. In this picture, what you see is the cage down here. here is where the tube is placed. This patient has a grade 2 listhesis. And for anatomical reason, the grade 2 listhesis, which is one of our indication for MIS DLIF, Cambine triangle is not safe because of the fall. The position of the nerve sort of covers the Cambine triangle completely. So here it's much safer to use the entry anterior to the nerve root. And that's exactly what you see here. The entry point here enable us to still go inside of the vertebral body without have to damage the nerve root in the process. Now, as well, this is, I think, an important picture that we see here that shows again that we are coming directly lateral and going across the vertebral body, as well as I have some picture that really demonstrate what exactly different between the OLIF and the MIS DLIF is. Here in the 5S1, you see the cage pins are superimposed. That meaning it's going directly horizontally. Here in the 4-5, it's a OLIF. You see that the cage pins are not superimposed. And in the next picture, you see it on a different patient, both L5S1. In one case, in the OLIF, you see that that the entry point is practically medial to the lateral border of the vertebral body. So you see that here. In the DLIF, you see that the entry point is exactly at the lateral border of the vertebral body. Is that well visible, Ali?
Yeah.
Now, this is the AP view. In the lateral view, if you pay attention, you see the entry point is exactly at the border of the vertebral body, but in the DLIF, MIS DLIF, the entry point is anterior to the border. So with these two pictures, you can always determine if a procedure is DLIF or OLIF. In the OLIF, you're obviously in the Cambine triangle, which is medial to the lateral border in the AP view, but exactly at the border of the vertebral body in the lateral view. And the MIS DLIF in the AP view, it's exactly at the lateral border in the AP view, but anterior to the posterior border of the vertebral body in the lateral view. If I show that on the model, it makes instantly sense. And again, here is the vertebral body, and I'm just going to put as an example of a nerve root to be able to visualize that. So if this is the vertebral body, this is the Cambine triangle, and this is the OLIF. And if you look at the OLIF in the anterior view, it makes sense that the entry point is medial to the vertebral body. In the lateral view, just on top of it. Now I'm going to position on the DLIF view. This is DLIF. Now in the anterior, it is just on the lateral border, but in the lateral view, it is deeper than the border of the bone. Does that make sense? Okay, so, and this little different give us the advantage of being able to all of a sudden add L455S1, but as well T12L1 to palette of the procedure that we can perform with this method, contrary to regular DLIF procedure. And again, here you see these are two different patients, obviously. In one patient, if you look carefully, one pin is here, one pin is here. In the other one pin is here, one pin is here. That just says that this is going more in the lateral direction, this is going more in the oblique direction. In both of them, the 4-5 is actually an OLIF procedure. Now, again, if you go back a few slides, now the question is, why do we do OLIF? We do OLIF so we are able to do T12L1, L4-5 safely, and L5S1. If we have an anatomic consideration like this, if we look at this anatomy, the nerve root literally covers the Cambin triangle is mostly eliminated by this configuration, but here we still have the possibilities to go laterally and perform the procedure. Now, and again, here is another example that we did a DLIF procedure. From the time DLIF procedure performed, I think we are still in our learning curve. For that reason, it is usually, at least in my experience, about 5 to 10 minutes longer than OLIF. I haven't figured out if this is just a learning curve process or is it truly going to be inherited, just a longer procedure. From the blood loss so far, it seems that it seems to be equal, no significant difference. Anatomical considerations are a little more difficult because here you go directly lateral, so many times you're in the way of your lateral X-ray, and that sometimes with some minor airplaning of the table we can overcome that problem. Additionally, I think what's important that direct thoracic interbody fusion is actually a modification of MIS DLIF. Even though we published that paper before, we have been doing direct MIS DLIF for a longer period of time. And when I started doing OLIF, at first, every second L5S1 OLIF had to be converted to the open surgery. And along the way, I noticed that I'm more successful. And when I started analyzing the data, why am I more successful? I noticed that my entry point is actually different, and that's how we invented this procedure that opens L455S1 as well as thoracic to this procedure. Now, obviously, L5S1 is one level, and lumbar spine has 5 levels. But considering L5S1 consists of 40% of the spinal pathologies, the clinical effect, clinical benefit of that is not just 1 of 5. The clinical benefit of that is up to 40 to 50% of all pathological spine cases. So this has a quite significant clinical impact. Now, I think that sort of sums up this presentation, and as before, with this procedure we don't have to cut any of the muscles that go multisegmental. We are not destabilizing the spine, and that is exactly the advantage why regular DLIF came to life. So the intention not to cause damage on the way of going there and doing the fusion. And here as well, a picture that shows the different, this would be OLIF, this would be DLIF, MIS DLIF. And again here, obviously these pictures are made for the OLIF, so the Cambin triangle is extremely generous in this picture. In reality, the nerve root comes here and goes down right here, so you have actually more access for the DLIF than the but as well, this picture as well shows that when they come together and crowd further down, why is it more difficult and more dangerous to the nerve to do a regular DLIF in the lower lumbar than in the upper lumbar region. So I think I explained what I need to explain. Ali, do you have any questions?
No, I think
You're good?
Understand it.
Now we are going to, this is a proof of concept study. So Ali did a good job at presenting our data with the statistical analysis that needed to prove in our first OLIF and then in our thoracic. Do you know if you are going to use just the regular statistic you use for the direct thoracic, or are you going to need more data?
Well, we're going to do a similar analysis. We only have 7 cases at the moment.
No, what is important is that almost every second to 2/3 of our 5S1s even though if we have been declaring them as a OLIF, in truth they are actually DLIF.
Right.
Now, just recently we started to declaring such. So Devin, who worked with us in the surgery, I'm training him to recognize which one is OLIF, which one is DLIF based on those X-rays. So even though our study is going to be on a handful of patients for safety, proof of safety and proof of concept, our true number of the DLIF is significantly higher. And I think it's even more important that those numbers are mostly L5S1, which is the most difficult area of doing this. But what statistical test are you going to use, Ali?
Well, so for the first few cases, we're just going to look at the safety. So we're just interested in the perioperative outcomes and compiling summary statistics of the blood loss and operative time, and then the complications immediately post-surgery. And then once we get a larger sample size, we'll be able to compare them to open equivalents in the literature, for example, by using t-tests or ANOVA.
Now, once we declare those OLIF that they are truly DLIF, our numbers are going to be in hundreds. And do you think there's a value of doing a meta-analysis to what we have been doing to papers that are out there, comparing to the regular traditional DLIF or the meta-analysis to the TLIF? Do you think it's
yes, sure. I mean, given the clinical significance of the L5S1, I think it'd be an interesting study to compare that group separately from the other cases. Okay.
I think that sort of sums up our new study, direct thoracic interbody fusion in minimal invasive technique. Thank you.